Hello. Yeah. Thank you, Dr. Ajit Babu. So this talk will also be a little short, so we'll catch up on time. So this is a study that we've done in our hospital to highlight the role of OCT in recurrent corneal erosion syndrome, which is something very common actually, but often underdiagnosed in the clinic. So this is typically what a classic recurrent corneal erosion syndrome cornea looks like. You'll see this whitish kind of a loose epithelium, and if you stain with fluorescein, it'll have negative staining around it. And recurrent corneal erosion syndrome is a relapsing chronic disease of the corneal epithelium characterized by repeated episodes of sudden onset of ocular pain, discomfort, watering, irritation, etc. Typically, these symptoms come up when the patient wakes up from deep sleep, and on sudden opening of the eyes, the symptoms start, and they last for a short period of time, from few hours to few days, and they spontaneously go away either with treatment or without. And so they are called the so-called morning symptoms. And pathology basically is that the attachments, hemidesmosomal attachments between the epithelial cells and the epithelial basement membrane gets damaged, and even when the new epithelium forms, these attachments don't form properly, and that's why this epithelium tends to keep getting ripped off again and again, causing recurrent symptoms. So the most common etiology for epithelial basement membrane is actually trauma. Commonly, fingernail injury is the most common. Typically, we see it in mothers whose children have put their fingers in the eyes. But paper edge, the paper cuts, and any other object, plastic toy falling into the eye, these are the common trauma indications that we've heard. Other than that, epithelial basement membrane dystrophy is a dystrophy of the epithelium, which is prone to develop recurrent corneal erosions, and various other corneal dystrophies also are prone, as is listed here in this table, and other conditions, etc. also you may see. So any condition, even a refractive surgery like PRK, when you're removing the epithelium with a blade, if the edge where ablation is not done, can start developing erosions as well. So recurrent corneal erosion syndrome, in between the episodes, the cornea looks absolutely normal. So if the patient told you that 3 days back I had these symptoms and he's come to your clinic, the cornea will be absolutely normal. You do OCT, you do clinical examination, you may not see anything. So history becomes very important, and it's important to proactively ask for these, when does these symptoms happen, if they and ask if this have happened before, any history of trauma in the past which triggered the first episode. And of course, when they come during the episode, then looking at them in the slit lamp, and also use of tools like the anterior segment OCT becomes important. So the purpose of this study was to report the findings of OCT in corneas, the recurrent corneal erosion syndrome, and the secondary objective was to see the role of PTK in treating this condition. So this was a cross-sectional observational study of 46 eyes of 34 patients performed at our hospital. All the eyes were scanned using the OptoView RTView 17-line raster acquisition protocol of the OCT, and the etiology was investigated, and the standard treatment protocol was started. Scans were obtained at various stages of the pathology and studied for different changes in the different layers of the cornea. So this is the typical layers in the epithelium in the OCT. You can see the epitheliofilm, epithelium, Bowman's epithelial basement membrane, and the Bowman's membrane in the magnified view of the lens. So we had patients with recurrent corneal erosion syndromes in 17 ladies and 11 men. 8 of these patients had underlying epithelial basement membrane dystrophies, which was 17%, and all the AIOS-OCT images were obtained were compared with normal AIOS-OCT images, and changes were noted. So these were the changes that were seen in the epithelium. We see changes in the epithelial basement membrane, Bowman's membrane junction, and then changes in the anterior stroma. So epithelial changes, the most common was epithelial edema, which is thickening of the epithelium, irregular breaks in the epithelium, seen in 40%, undetected epithelial basement membrane in 53%, intraepithelial basement membrane. I'll show you images of all of these, how they look, and intraepithelial inclusions. The BM changes, which is the Bowman's membrane, basement membrane changes, were thickening of the junction in 71%. Hyperreflectivity was the most common sign across the board, 88%, and slit-like spaces in between the two layers. And stromal changes like anterior stromal hyperreflectivity, which is basically because of scarring in the anterior stroma. So I'll just show you what these changes look like in the OCT. On the top, you can see the thickening of the epithelium, which is epithelial edema. Intraepithelial basement membrane is that hyperreflective line there, and intraepithelial hyperreflective inclusion is that thickened mass in the epithelium over there. Irregular breaks in the epithelium with overlying intact tear film, and that is the absence of the epithelial basement membrane in this image here. The BMBM changes were slit-like spaces. So these have not been described before our study. There have been other studies, but this is something we found very commonly in our population, and hyperreflectivity and thickening of the BMBM junction, as is shown in the second image. And finally, in the anterior stroma, you can see anterior stromal hyperreflectivity, which can be either from edema or from scarring. So 11 of these eyes underwent excimer PTK between 1 to 15 microns, following which 10 of these 11 eyes had complete resolution of symptoms as well as OCT changes noted previously. One had partial resolution. So similar study of 25 eyes is the only other study by DS Feggio et al. And the major difference our study could pick up was various changes at the level of the BMBM junction, which were not mentioned in the previous study. In fact, they were the most common findings that we found. And this layer should be studied in greater detail, as the tight junctions are present here, and this is the actual site of the pathology rather than just the epithelium. Epithelium is just secondary changes. So you can see the percentages in comparison to their study and ours, and these were the parameters which additionally we found in our study. So to conclude, corneal OCT is a useful tool to study the pathophysiology and of recurrent corneal erosion syndrome and its evolution through various stages of the disease. It also helps in planning its management, especially when deciding the depth and size of ablation during PTK procedure. So you can actually see how deep the pathology is and accordingly plan your excimer ablation. We don't need to really go deeper than 10-15 microns, because that's where the pathology really is. Thank you.
Thank you, Rishi. Now we move on to the next talk, vitreoretinal interface disorders by Dr. Ajit Babu Marji. Yeah, yes, Madhukar, you can stay.
Hello? Hello? PTK. Yeah, so the machine that we are using, which you are also using, is the Schwind, which it removes more epithelium in the periphery than in the center. So the refractive effect of that is almost near zero. So if you go for a small optic zone, it may cause a hyperopic shift. But again, our ablation depth is so small, 10-15 microns, that itself will not really cause much of a refractive effect. So it's pretty much safe. Yeah.